Thank you.
Hi all, I'm Philip McNamee. I'm a researcher based in East London NHS Foundation Trust, and I currently manage a trial that's looking at the implementation of Dialog Plus within chronic depression services. But as part of that, I do a lot of training and development of the intervention itself, and that's why I'm here today. And I'll just let Vicky quickly introduce herself, who she'll be popping in and out today.
Hi, I'm Vicky. I'm a professor at Queen Mary and run a number of projects on Dialog Plus, both in the UK but also more widely around the world. Phil's going to be doing the majority of the training today. I'm just going to be here to help facilitate some of the practice sessions when you're in the breakout room. So I'll be popping in and out today of the meeting. So I'm gonna say hello and goodbye at the same time, and I will see you all for your skills training session in a bit, and enjoy.
So I've now just shared my screen, so hopefully everyone can see that. I'm just going to give a quick overview of the 3 training sessions that we're going to do over the next month or so, and kind of what the objectives of those 3 sessions are. I know some of you may have attended Dialog Plus training before, but that was pre-COVID, and you've probably forgot everything that you went over with Vicky at that point. And I know some of you are very fresh to this. So we're going to start from the very basics of kind of Dialog Plus. And this is what today's session is all about, just as an introduction to the intervention, kind of what the developmental background of Dialog Plus is, and then also some kind of technical aspects of kind of how to navigate the intervention and the associated app, which is hosted on a tablet. And then we'll get into some skills practice at the end in these experimental break rooms that we're going to try. So, you know, this is a new way of training, kind of a mass of people. So please be kind and stick with us as we kind of experience some teething problems. Basically, what we used to do is we used to get everyone in a kind of a big room for a half day or a full day session and kind of go through intensively. And I just don't think that would work well over Zoom. Kind of Zoom fatigue is a real thing, and people get very bored and tired after a few minutes, after kind of an hour or so. So we're going to do 3 kind of disparate yet interconnected sessions over the month. And then the second session, which is on the 1st of December, we'll really be looking at reviewing and refining the skills that we've developed in this session, and then practiced kind of some home-based learning, and also exploring some of the delivery barriers, clinical issues and concerns that you have as clinicians. Kind of the biggest feedback that we often get, and something that Michaela's talked to us about, is it's fine to be taught how to deliver this intervention and how to use it with your caseload. It's another thing implementing it within the clinical reality of your services. So what we really want to get from this second session is kind of what are some of those barriers, whether they're cultural, technological, clinical, and really explore some solutions to those and work in this solution focused way, which is at the heart of Dialog Plus. And then the third session, kind of after some actual implementation and practice and piloting of the intervention within your service and within your team, we'll then look at kind of how we can integrate that into clinical systems and look at an implementation plan locally and nationally. So that's what we plan to do. Unfortunately, there will be some home-based learning to support the kind of the embedding of these skills. Sue has kindly sent out a worksheet that you'll see in your email inbox after this session, and there's a worksheet that we're going to ask you to work through, and that's basically after this session just to practice with family, friends, or your support bubbles, or whoever you have access to, and that can be both face-to-face or virtual and remotely. And then after the second session, we're going to ask you to deliver Dialog Plus to 1 to 3 of the service users on your caseload, to look at kind of the implementation and clinical issues with using it, just so we can have a kind of a more pragmatic picture of what it is like to deliver this and what some of the barriers are to implementation. So today, the learning objectives, what I hope you get from this session is that you familiarize yourself with the developmental background of the intervention and understand kind of its kind of why we're so kind of keen about implementing it, and also kind of the strong evidence base that underpins it. To demonstrate the basic functions of the app itself or the intervention and familiarize you with the process of navigating that. For you to observe how Dialog Plus is used in practice, and then finally begin kind of developing these skills in order for you to deliver it within your service. Okay, so Dialog Plus, let's begin the first session. And we begin by kind of giving you a kind of a contextual overview of how this was developed. So I work in the unit of social and community psychiatry, and kind of what social psychiatry is all about is what happens between people, how these interactions impact and shape mental conditions and mental health, and also the services that are available to treat them. So if we adopt a social perspective of mental disorders and understand kind of mental conditions, including psychosis, as defined in social interactions, occurring in social interactions, and diagnosed as kind of occurring within these interactions between people, then the solution must be that we have to treat them with an understanding of how these interactions impact on the individual. So what kind of Dialog tries to do is to take this really key important interaction between you and the service user and kind of make it more clinically effective in itself, in just that way we interact and converse and speak with our caseloads. There's also a tendency for kind of medical treatment or psychiatry generally to focus on the deficit of mental disorders. So we look at kind of what is lost rather than kind of what is gained. So what Dialog Plus does is it is a treatment, it's a resource oriented intervention. And what that means is that it adopts this tradition of looking at what is available to both us as clinicians, but also to the service user themselves, and how we can utilize those resources either in a better way or a more efficient way. And that all then becomes part of the care planning and treatment. And this is independent of diagnostic categories. So we'll get into later how kind of Dialog Plus is very flexible for kind of diagnostic categories, but we're obviously going to focus on psychosis today. So these are just some other resource-oriented models, which are kind of treatments or approaches that make use of social networks or resources that are available in the community, within the household, whatever that might be. And there was a kind of a conceptual review by Professor Preeb, who kind of developed Dialog Plus and looked at all these different ways of working in a resource-oriented way. So things like befriending services, music therapies, open dialogue, which is obviously different to Dialog Plus, peer support workers. These are all using these interactions, these social networks that are available, and utilizing them in a way that's clinically effective. So worldwide, or at least kind of within Western psychiatry, millions of patients have routine meetings with mental health professionals. They kind of have these regular meetings once a month, every 6 weeks, whatever it may be. And these are just used for kind of conversation, monitoring of symptoms, referral to other specialized treatments, but just as a kind of as a check-in. And what the thinking behind Dialog Plus is how can we make a radical change to the way this time is spent so that it becomes more than just a kind of a monitoring exercise and more than just a referral exercise, but becomes therapeutically effective in and of itself. So using these routine care planning meetings and making those kind of therapeutic in themselves. And it began with a simple scale called the Dialog scale. And this was an 11-item quality of life measure that asked the service user, how satisfied are you with a kind of ... and 11 different areas of living and life. And the top 8 here are kind of life domains. So these are what we call patient reported outcome measures. So this is kind of a subjective evaluation by the service user about the satisfaction with these different areas. So mental health, physical health, job situation, accommodation, leisure activities, partner/family, friendships, and personal safety. And the bottom 3 were patient-reported experience measures, or PREMs, or 3 treatment aspects. So how satisfied are you with your medication, the practical help that you're receiving from the service, and the meetings that you're having with your mental health professional. Now, taken together, these 11 different areas kind of create a really detailed and holistic picture of the quality of life of the individual. And the way it works was that the service user rates each of those areas on a scale from 1 to 7, 1 being totally dissatisfied and 7 being totally satisfied. So by quantifying their satisfaction, just on this very simple quality of life scale, both the clinician and the patient could see kind of visually where they sit both across as a whole, but also between the different areas as well. And a really kind of key aspect of this also was after they answered each of the items, they were also asked, do you need more help in this area, yes or no? And what this did was empowered the service user to set the agenda of what they wanted to talk about within this routine meeting. So they might be very dissatisfied with physical health, for instance, but did not feel that they needed any more help from the clinician at that point. And so that would not be discussed. And this was kind of used as a framework to set an agenda for the preceding meeting that would happen. So just this very simple 11-item dialogue scale was used in a trial, a pan-European trial, RCT. And it included kind of over 500 patients with psychosis in 6 different European countries. This was kind of back in the noughties, so it was published in 2007. And clinicians were asked to just use this scale at the beginning of a session once a month for 6 months. And on average, it was used about 4 times. Sorry, they were asked to do it for 12 months. Sorry, and once a month for 12 months. So on average, it was used around 4 times over the 12-month intervention delivery period. So the implementation of it wasn't great. It was around a third of what it should have been being delivered as. However, with that kind of poor implementation, it still had positive outcomes as a result of just doing this very simple scale. So there was improved quality of life at the 12-month follow-up period. There was improved treatment satisfaction, again at the 12 months, and there were fewer unmet needs reported by the sample when they were followed up at 12 months. So just by doing a quality of life scale that asked about satisfaction at the beginning of a routine session led to improved outcomes. However, this was a very small effect size. So what the feedback was from these European clinicians was, right, great. This is obviously helping in some way. We're not sure how, but what do I do with this routinely collected data? So I collaboratively, we fill in this form, we fill in the scale together. How do I use that like in a clinically appropriate way? How do I embed that in my practice so I'm not just collecting data for data's sake, but actually that is being used to improve outcomes even more? And this is where Dialog Plus came along, because what Dialog Plus tries to do, it takes the scale at the heart, and we still do the scale, we still ask those same 11 questions based on satisfaction. But then we bring together these 4 different areas of research: quality of life research, concepts of patient-centered communication, IT development, kind of how can we use the tablet in a clinically effective way, and also underpin it with kind of a therapeutic model. And that one is solution-focused therapy, which we'll talk about a lot today. So bringing these 4 areas together, the team created the Dialog Plus intervention. And this is what the Dialog Plus intervention looks like on the home screen of the tablet. So this is obviously in landscape mode, but obviously this is just the first kind of step in a many-step process. But we always, like I said, we always start with the dialogue scale and establishing and assessing the patient's reported satisfaction with these different areas of life. So you can see there at the very top, it says, how satisfied are you with your mental health? The question stays the same. There is a 7-point Likert scale with the values underneath. So we go from 1, totally dissatisfied, to 7, totally satisfied. I probably got that wrong. 1 is totally dissatisfied and 7 is totally satisfied. And underneath that, you see the question, do you need more help in this area? Yes or no? And basically, you need to fill out both the question, the satisfaction question, and the need more help in this area question before the app allows you to move on to the next question. If for whatever reason a service user doesn't want to answer a question, that's absolutely fine. It just needs to be left blank. So, and then along the left-hand side of the screen, you can see the 11 different domains listed. So you can see mental health is the first question, and that's why it's got the scale. And then underneath physical health, job situation, etc., etc., etc. And at the beginning of every session, this scale should be completed. And that's a collaborative effort between you as a clinician and the service user. We do it on a tablet to kind of democratize the power balance between you two. So by having a tablet that you can both access, and it's very transportable, it can be passed between both parties. So kind of both are contributing to this care planning and this way of working. So if you're doing it on a desktop computer, you've usually got your back to the patient, and that just instantly creates this kind of dynamic that's not collaborative. And if it's on paper, then you lose that ability to kind of pass it back and forth between you. Along the bottom of the screen, you can see these different words in blue: review, select, discuss, action items, and finish session. And these are kind of the milestones that you work through as you do the Dialog Plus session on the tablet. So obviously we're in the review section because we're reviewing the satisfaction and the quality of life of the individual at this stage. The next stage then is select. And once the service user has answered all 11 items, you get a overview of quality of life. So the blue lines show the current ratings that have been given in that session. So you can, at this point, compare and see across these different domains how the quality of life is rated differently. So you can see here partner and family is rated very highly. They're very satisfied with their partner and family. Medication and job situation is rated very dissatisfied. So you can see areas which might need attention or areas that kind of you as a clinician want to discuss. The blue ticks on the right-hand side of the screen denote the questions that have said yes, they want more help in that area. So that's just a little visual cue for you as a clinician to see which of those domains or areas that the service user has requested more help with. And in addition to kind of comparing within that rating, you can also compare against previous sessions. So the boxes along the top with the dates in, they denote every session that has been inputted into the app. And you can see the dates that they were done. And then that also gives you the possibility of comparing the orange line to the blue line and seeing where there has been increase in satisfaction across time or potentially decrease in satisfaction across time. And this just gives you kind of a framework to ask about things that have changed. So for instance, like leisure activities, it's only gone down from a 5 to a 4, but it might be something that over time you see increasing, incrementally decreasing. And it might be a kind of a trigger to a conversation that you would never have had if you'd have not seen this kind of creeping decrease in satisfaction in an area. You can also see kind of where satisfaction is improved. So on personal safety, for example, it's gone up kind of 2 whole points from a 4 to a 6. And by kind of doing a little bit of positive reinforcement or bringing attention to areas that are increasing satisfaction, you might uncover a resource or a kind of a strategy that is being used unintentionally that is increasing satisfaction, which could be used in another kind of domain later on in the session. So we're on select, we're on the second milestone of select, and this is to select up to 3 areas to discuss in detail. And we always suggest selecting up to 3, just because it takes around 10 minutes per domain to discuss in detail as part of this intervention. Any more would be too burdensome and it would take too much time. So if you really need to go into detail about one domain, then that's absolutely fine, but just never more than 3. and you select that domain by physically pressing on the title of the area. So where it says kind of medication, you would click medication, it would highlight that in blue, and that would then set within the app the agenda for the remainder of the meeting. So here, for example, in this scenario, we selected job situation because that has gone down quite severely in satisfaction since the previous session. We've selected friendships for the same reason, and medication because it has been consistently rated as dissatisfied. And it's also something, because it had a tick, the blue tick at the end, it is something that the service user wanted to discuss. Now, as clinicians, I know that you will always have areas that you want to discuss, and presumably a lot of the time that will be mental health, because that is kind of, you're a mental health professional, that's what you want to discuss. What we try and get across as part of this is it is up to the service user to select the areas that they want to discuss. Ultimately, they're the ones who are going to have to kind of enact these actions to improve satisfaction. So it needs to be something that they're motivated to change, or motivated that they kind of need help in that area. Any kind of concerns that you have can be discussed at the end, but shouldn't influence the selection of the items at this point. So once you've selected these 3 different areas to discuss, you then obviously go to the discuss milestone at the bottom of the screen, and you just click discuss on the tablet, and that then leads to a pop-up window like this on the tablet. So you get a number of pieces of information at this point. You get to see the area that was selected to discuss. So you can see medication in the top left-hand corner. You can see the rating that was given in this session, which is a 2. And then underneath that, you can see this 4-step approach based on the principles of solution-focused therapy. Now, we're not expecting you to be experts in solution-focused therapy, although some of you may be, or some of you may be familiar with it. What we always say is that if you just follow these 4 steps, you will be working in a solution-focused manner. And that's kind of all we expect. So I'm going to take you through kind of stepwise the 4 different steps as part of this process, and kind of use an example to show you how that conversation might go, and how this might kind of structure a conversation as part of that. So step 1 is all about understanding and eliciting information that you might not have received so far from the individual, to find out why this domain, so why they're dissatisfied with the medication, and why this rating, so why they're very dissatisfied, why have they given it a 2. And as well as part of that understanding process, the principles of solution-focused therapy tell us also that we need to kind of always adopt this kind of solution, like not get bogged down in the problem, but constantly strive towards the solution. And as part of that, we look at, so why this rating and not a lower one? So it's a 2, you're very dissatisfied, and I'm hearing that and I understand that, but you're not a 1. So what is working? Why aren't you a 1? And even if the individual does rate themselves a 1, there's always something that's available to kind of, as a building block, as a foundation to build up from there. So even though they're completely dissatisfied with the medication, as the case may be, they are still attending the session, they are still there, they're still talking to you, they want to make a change. And that is just something that you can kind of hold on to and build from there. And this is all about, the whole thing of Dialog Plus is all about incrementally, very slowly moving our way up this satisfaction scale for the individual. So we might not see huge advances or huge changes, but it's just about trying to enact that change. So understanding is saying, eliciting the information, getting a clear picture of why that is the case, and then but also establishing what is working. So for example, they might be on kind of very heavy medication, it's helping with symptoms, they hear less voices, but there is a lot of side effects of the medication. So they're not sleeping too good, they've got very disturbed sleep, and they're putting on weight. So it's these side effects that are making them very dissatisfied. So you've established that actually the medication is working, it's doing what it should be doing, it's decreasing these symptoms, but there's also obviously psychosocial side effects which are making them unhappy. And that is something that we can then address through the remainder of the steps. So step 2 then is looking forward. And this is adopting kind of a future perspective and understanding what the long-term goals are of the individual or what the best case scenario is. So as part of looking forward, we ask, well, what is the best case scenario? If you were a 7, if you woke up tomorrow and you were a 7, you were completely satisfied with your medication, what would that look like? What would that feel like? How would you describe that to me? And just establish, and those long-term goals, those best case scenarios might not be achievable, but that doesn't really matter, because all we need to know is what the best case scenario is, and understanding that gives you a lot of information. And once you've established what that best case scenario is, what a totally satisfied life looks like, we then move on to, well, what's the smallest improvement that we can make? So what can you do in the next 24 hours or between now and the next session to make a small improvement to your satisfaction with the medication? So it might be that the medication can't change, but that we can do something potentially about the sleeping schedule or the weight gain or whatever that might be. And again, it's all about just moving incrementally up this scale. So it's not about jumping from a 2 to a 5 immediately. It's about saying, how do we take you from a 2, very dissatisfied, to a 3, which is fairly dissatisfied? So you're still dissatisfied, but you're a little less dissatisfied than you are today. How can we make that small improvement? Step 3 then is considering options. And that is where we kind of take a lateral approach to thinking about what is possible. And this is not about kind of what we're definitely going to do and setting a care plan and setting actions at this point. It's just about considering what is possible. And there's kind of, this breaks down into 3 different parties. The first is, what can a patient do for themselves? Are there any resources or strategies within their grasp that they can use to help with these negative side effects that they're experiencing? The second is, what can you do as the clinician? Is there someone that you can refer to? Is there something as a team that you can do? It might be a medication review with a psychiatrist, or kind of referrals onto other people, or it might be kind of writing a letter if it's about accommodation or whatever that might be. And finally, it's what can others do? So what can friends, family, social networks, peer support workers, kind of within this social network, what can they do to help with the things that have been discussed previously? And once you've had that kind of consideration, you've considered those options. And this, I should point out, is very much you facilitating that thought process for the individual. So it's not about you saying immediately, well, this, you can do this, this, and this. It is about you facilitating that process of thinking about what is available. And you might get a lot of pushback. In fact, I can guarantee that you will get a lot of pushback, because people say, well, if I knew what to do, I would be doing it already. But actually, that's not, a lot of people, the solutions, not the solution, but a solution is available, which isn't being utilized or could be utilized in a better way. And what this process is about is thinking about all the solutions that are available and how we can utilize them for how the service user can utilize them better. And then finally, step 4 is agreeing on the action. So this is where this is kind of the only thing that you put into the app. And this is where you write down the action items that have been agreed upon, that the service user feels comfortable committing to, and what you will review in the next session together. So you press the add button. This brings up kind of a pop-up. You type into the app what the action items are. These should be very brief, very precise. It should be very clear whose responsibility it is to complete the action, whether it's yours or the service users or a family member or a friend. And that is the only thing that is kind of reviewed at the next session. And once all the action items have been inputted, and we're not asking for very, very detailed care plans here. We're asking for kind of 1, 2, or 3 very brief and precise action items. It can be as simple as setting an alarm on your phone to wake up at a standardized time. It can be kind of feeding the cat regularly, to give a routine. It can be to wake up and make your bed, just so you're kind of having a routine and you kind of want to, so you're not tempted to go back into bed and nap. So it's these different things that you can do. There's nothing too small. And in fact, it's what clinicians often do is set too kind of complex or high level goals straight away, rather than just breaking them down to very simple, achievable things that can happen between now and the next session. And obviously, kind of within COVID restrictions, we also have to be mindful of what can be done within the guidelines currently. So that's kind of a very quick overview of how the intervention works on the tablet. I'm now going to go into the research that was done and the evidence base for it, and kind of why we're in the position we're in now, kind of delivering it all over both Wales and England, but also kind of globally as well. So this new Dialog Plus intervention on the tablet that brought together these 4 different areas was tested in a cluster randomized control trial in London. It involved 40 clinicians with 180 patients, and the Dialog Plus intervention was tested against an active control. And what the active control was, it was just the Dialog scale. So one group would get the full Dialog Plus intervention with the 4-step solution focused approach, and one would just get routine care as normal, and then they would fill out the Dialog scale, the quality of life scale, at the end of that session with no clinical input from the clinician. So we were basically controlling for the Dialog scale, which had already been shown to be effective at increasing outcomes. So it was a very good comparison group to have. There was a 6-month intervention period, so we asked clinicians to deliver the intervention for once a month for 6 months, and then we assessed outcomes at baseline 3 months, 6 months, and 12 months. And the results were very positive. So at all outcome time points, so at 3 months, 6 months, and 12 months, those in the intervention group, those who received Dialog Plus, had a better quality of life compared to the comparison group. And not just that, but the change on quality of life, the effect size was at least as large as that for CBT. So CBT is a very essential, important psychosocial intervention, but it's, you know, it's high level. You have to be thoroughly trained in it, and it's the manuals about this thick, and it's you know, it's a commitment. Whereas Dialog Plus can be trained in about an hour and a half. Anyone can do it, from support workers to consultant psychiatrists. It's very flexible in who can do it and how it's delivered in comparison to CBT. So to have the same effect size on the impact of quality of life was incredible. There were also lower levels of general symptoms throughout, as reported on the PANS. So basically, the kind of the general psychiatric symptoms had been reduced for those who received Dialog Plus. And after 1 year, so with a 12-month follow-up, there was better objective social situation for those who'd received the intervention. So basically, you needed time, the 12-month period, to actually enact changes to the objective social situation. So this wasn't just kind of proms, you know, subjective reports by the individual. This was actually tangible things that had changed for the better in the lives of those that received Dialog Plus. And finally, there was cost savings after 1 year. So it wasn't just cost effective, it was actually saving costs over the year. And that was because there was a huge reduction in hospitalizations as a result of receiving this form of care planning. And that obviously the health economic analysis was very positive, because it showed that, you know, the services who were using this were saving money over time. So I'm just going to give you a little insight into the patient experience and what some of the patients said about receiving the intervention as part of this trial. So one said, the questions made me look and reflect on my life. I'd never addressed some of the issues that I came across in Dialog Plus. And this obviously speaks to this idea of working holistically, using the scale to kind of break down life into these 11 different areas, and then through the 4-step approach, building it back up into a kind of a tangible care plan. I think a lot of time we avoid things that we think we can't help or address. So kind of by using this very strict structure, it kind of forces people to address things that they weren't bringing to the sessions necessarily. You start improving yourself. Sorry, this is the second quote. You start improving yourself because you're aware of it now. It made me realize what I needed to do. So this idea of kind of empowering the service user to be an active participant in their own recovery, and allowing them to come up with items, but also enact them over time as well. Dialog Plus was more structured, more professional, more focused. Constructive things were being done about certain issues. And then, so that was service user perspective. And this is what some of the clinicians who were part of the trial said. It was structured, it was easy for them, i.e. the service users, also to follow what we are talking about. So this idea of having a structure allowed them to kind of be more transparent and to kind of follow the agenda, what was being set very much by the service user themselves. I got so much more information out of him. So this idea that you're kind of eliciting much more information about the personal life and perspectives of the individual and how that helps then in the care planning process. And one particularly effusive clinician said, I found it the most empowering tool in the 10 years I've been qualified as a clinician by far. It definitely changed our therapeutic relationship. By the end, really, he was very, very much in control of his own care. So as a result of these very positive findings, there's been a kind of a wide rollout. But why was it so effective? Well, actually, I don't have the answer to that question, but we can kind of hypothesize about why that might be. So kind of one of the big things is that it directly addresses patient concerns. It allows the patients to kind of rate the quality of life on these different areas, and then allows them to pick which areas they want to discuss with you as a clinician. So it kind of is against this paternalistic view of kind of psychiatry, and it very much empowers them to talk about their own concerns and what's affecting their mental health. And this also feeds into this idea of empowering patients. And finally, it helps with communication. So it gives you a structure, a framework, a guidance to work from, and that you bring all your clinical skills, kind of what makes you a great clinician, and then you use that framework and work from it. So I always say how I do it, how I do Dialog Plus and how you do Dialog Plus will be completely different. This is not supposed to be a tick box exercise. This is not supposed to replace you as the clinician. What this does is provide a structure and a framework from you then to work from, to ensure that you are working in a patient-centered way, that you are working holistically, and that you're creating a care plan that kind of meets the needs of the individual. So kind of in terms of implementation, which is at the stage right now within NHS Wales, it's a great tool because the routine data that you're collecting can be used in a number of ways. And I'm not going to really get into the way that the data can be used, because what's important for you is how it's used clinically in these routine sessions. But as a service, it can be used as a way as an assessment for the individual, for care planning, as we've discussed. It's a kind of a therapeutic intervention, which improves outcomes, but can also be used as an evaluation, as a service, as a trust, as a health board, wherever that may be. And that kind of routinely collected data can be used very effectively. And that is just all part of, this is not an additional job that you're doing. This is not, you're having to fill out another kind of patient reported outcome. It's part and parcel of the intervention itself. It has very clear core principles. So, we've talked about them. It's based on solution focused therapy, and it's got a very intentionally brief manual, about 20 pages, can be read in half an hour. And you understand the way you should be working and how this should be applied. As I mentioned earlier as well, it's got flexibility in the sessions and application. So it can be adapted to different diagnostic groups. Like I said, I work on a project looking at chronic depression. We use in older adult services, but it was obviously developed for early intervention services, like the ones that you work in. And currently, it's kind of Dialog Plus has gone global. It's being implemented in over 20 countries across 4 continents. And it's always been able to be implemented, no matter the differences in the services, how they're organized or how they're funded. It is so simple, and it is kind of the principles are so clear. It's always been able to be implemented, no matter kind of what the service structure is. So it'd be really interesting as part of this process with you to look at what some of these implementation barriers are within your teams, and kind of address those sequentially. So just to say, it's freely available as an app for iPads. So not available on iPhone, but you can download it on an iPad if you have one of those. And then Android platforms, you can either get it on Android tablets or on Android smartphones. The manual is available on the website, but we'll also send it out as part of this package. There's over 16 languages available, not Welsh, unfortunately, quite yet. There's an operational guide as well to teach you how to use the app. and also an adherence scale if you need that, and background information publications, which I'm sure you're all aware of already. So all the information is on the website, although you can ask me questions now as I just end this slideshow. Stop share. So has anybody got any questions at this point before we go on to watching some videos about how Dialog Plus is used in practice? Don't see any hands. So I'm going to share my screen again. So at this point, we're going to watch some videos that we commissioned. Just as kind of a pre-warning, they're a bit sterile. So this is not kind of what a normal session would look like, obviously, but it's just it just gives you an indication of how the tablet should be used as a face-to-face interaction, and kind of what we've talked about earlier about the different kind of steps of the intervention. We'll go through that. So I'm just going to share my screen again. No. Okay, here we go. So this is the training videos that we use. So this is from how you select a topic with, so imagine we've completed the dialogue scale, that's all been completed, you've done your kind of comparison and you've done your positive reinforcement, and now you're trying to select the topics to discuss in more detail.
So Lauren, you've
can everyone hear that?
Yeah. Just rated these 11 items on the dialogue scale, and we can look down and compare today's ratings against the previous ones. So we can see here that satisfaction with your partner and or family has gone from a 4 to a 6 since the last time we met. So that's encouraging. Can you think of anything in particular that's caused that movement?
Well, last month, me and Mum were arguing quite a bit about money, but all of that's improved now.
Okay. Is there anything in particular that you think has helped with improving things between you and your mum?
I think we're just communicating better. We're listening to each other and actually talking.
Okay, that's really good to hear. So these lower rated items here that we can see on the screen, which one of these do you think you'd most like to talk about today?
Well, I think the physical health is definitely one. Mental health and medication, they've all been causing me problems this month.
Okay. If you look here, we can see that medication's been consistently rated low, and you scored it a 3 today. So shall we discuss that this session?
Sure, let's talk about medication.
Okay, great.
So that was kind of example of how the tablet was kind of present at all times. Both the service user and the clinician could see the ratings, and as they were comparing them and kind of reviewing them, there was kind of a structure to that conversation, because the scores and the comparison between scores was eliciting more information. So now they've selected these items to discuss in more detail, and now we're going to start the first step of the 4-step approach, which is understanding.
So Lauren, can you tell me a bit about why you're dissatisfied with your medication, and perhaps a bit more about your experience after you take your medication?
I'm just really unhappy about it, to be honest. It makes me drowsy, I can't concentrate in the day, and I really would like to come off it, but I don't think that's possible.
Okay. Well, perhaps through this discussion, hopefully we can come up with some ways that we can help increase your satisfaction with the medication.
Okay.
So even though you're dissatisfied and you're scoring it as a 3 here today, at least you're not down at the very bottom of the scale here. So what's helping you from being here to being a 3? So stopping you from being totally dissatisfied?
Well, I've considered them 3, which is good. It's helping me to function better. Like I said about my mum, my relationships are a lot better. I can talk to my family now.
Okay. So although you don't like taking the medication, it is helping you in some ways?
Yeah.
Okay. Well, that's good to hear, but I can see why you're still dissatisfied. So should we see if we can come up with some factors that can help increase your satisfaction with your medication?
Yeah.
Great.
So you can just see how that the clinician, Lisa, used the ratings to understand kind of what was working for them, even though they were dissatisfied still, and now move on to step 2, which is looking forward and adopting this future perspective.
So Lauren, what would a 7 on the scale be like for you? So totally satisfied whilst you were still taking the medication. What would that look like for you?
Well, I suppose the best would be to be medication free, to not have to rely on the medication, because I hate taking them.
Okay. But what about if you were a 7 up here, totally satisfied whilst you were still taking the medication? What would that look like?
Well, I guess I wouldn't have any side effects. I wouldn't feel shattered all the time. But to be honest, I'd really like to be off it completely, or at least to reduce it, because I think it's helped me put on weight as well.
Okay. So that's maybe a long-term outcome, something we can work towards reducing the medication that wouldn't be achievable right now, or maybe even in the next few months. So what I'd like us to think about is some small differences that may still have a meaningful impact on your satisfaction and possibly get you moving up the satisfaction scale. So we can see here today you rated yourself as a 3. What do you think we could do in the next couple of weeks to move you up 1 here to a 4?
I don't really know. It would be great if I could come off the medication, but I'd like to not feel lethargic during the day. It's like I'm having to take naps in the afternoon, and it's just eating into my day, and I swear it's the medication that's doing that.
Okay. Is there any things you can think of that would maybe perhaps help with that drowsiness during the day or help keep you more active during the afternoon?
I haven't noticed that when I go out shopping or whatever, I'm not as tired, and I'm not having to take so many naps compared to when I'm just, walking around the house. Because then I just have to sit down for 5 minutes and I'm out. I have in the past missed appointments with friends and family. I've missed coffees with friends, and the other day I actually missed an appointment with my mum, and she was really upset and angry just because I was having a nap.
Okay. So if we could address that drowsiness in the day, that would be perhaps a way of improving your satisfaction on this scale in the short term, and maybe also improving your relationships with your friends, your family, your mum, because you'd be better able to do things with them during the day.
I suppose so, but I don't really know how I could change that without coming off the medication.
Right, I'm just going to stop there because I'm very conscious of time, and I'm keen for you to get some kind of skills practice in. So what we're going to do now is we're going to go into some skills practice, and